I'm David Robel, Dean of the College of Arts and Sciences at the University of Oklahoma. A warm welcome to our audience. I see just a few more people are getting on, but we've got a nice crowd for the presentation. Thank you for joining us for what I know will be an engaging and enlightening discussion with two of the nation's foremost vaccine scientists and public scientists. The OU Arts and Humanities Forum, the Office of the Vice President for Research and Partnerships, and the College of Arts and Sciences are very proud to sponsor today's program, which is titled Preventing the Next Pandemic, Vaccine Diplomacy in a Time of Anti-Science. Our presenters today are Drs. Peter Hotez and Maria Elena Bottazzi, co-directors of the Texas Children's Center for Vaccine Development. Together, they're leading a team of researchers who are committed to creating safe, effective, accessible vaccines for COVID-19 and other coronaviruses. They're not just at the forefront of vaccine development, but are also among the most prominent and effective proponents of scientific understanding as the core foundation of public health. Dr. Hotez is an internationally recognized physician scientist in neglected tropical diseases and vaccine development. You've likely seen him on television interviews with BBC, CNN, Fox News, MSNBC, and in newspaper interviews with the New York Times, USA Today, Washington Post, and Wall Street Journal, and many others. Dr. Hotez is frequently called upon to testify before the US Congress and has served on infectious disease task forces for 2 consecutive Texas governors. For these efforts, he was named by Fortune magazine as one of the 34 most influential people in healthcare in 2017. Dr. Hotez is the author of a number of landmark studies, including most recently, this wonderful book, Vaccines Did Not Cause Rachel's Autism, My Journey as a Vaccine Scientist, Pediatrician, and Autism Dad. And his new book, Preventing the Next Pandemic, Vaccine Diplomacy in a Time of Anti-Science, will be published this spring. Dr. Bottazzi is an internationally recognized vaccinologist and global health advocate for neglected tropical diseases and distinguished professor of biology at Baylor University. With more than 2 decades of experience applying the product development partnership model, she's built sustainable biotechnology capacity and successfully transitioned several NTD and emerging disease vaccines, for example, hookworm and schistosomiasis, from the bench up to phase 2 clinical trials. As a global thought leader, Dr. Bottazzi has received numerous highly regarded national and international awards and has published more than 130 scientific papers and has participated in more than 200 conferences worldwide. Dr. Hotez and Dr. Bottazzi, thank you so much for sharing your time and expertise today, and welcome to the Humanity and Health webinar series.
Thanks so much for having me today and
Thank
for
you.
having us.
I'd like to just jump straight into the key questions that I think are on everybody's mind. Dr. Hotez, I'd like to start by having you take a few minutes to explore your experience with coronavirus vaccines and your work at the Texas Children's Center for Vaccine Development, and explain for us what makes COVID-19 so different from previous outbreaks that we've seen.
Well, thanks so much, Dean Robel. By the way, you forgot the most important part of the introduction, which is that my youngest son, Dan, is an OU graduate who graduated last year as a petroleum engineering major, and that brought my family many times to Norman, and we just have fallen in love with the campus. And I've done a fair bit of writing in that beautiful main library there. So some of that book that you see in front of that you just talked about, and the new one was written in the main library at OU. We've Mary Lane and I have been working together for 20 years, and we've have a program developing vaccines for what are called neglected diseases. These tend to be diseases of the poor, people who live in extreme poverty globally, and there's a need for vaccines for those diseases, except there's a big market, but not a commercial market or a conventional commercial market, because they're vaccines for people who ordinarily can't afford to pay for them, or oftentimes countries or governments that can't afford to pay for them. So in addition to doing interesting science, applying biochemistry and molecular biology and immunology to making vaccines, we're also trying to explore a sustainable business model for how you actually get these vaccines accelerated. And that's an important message for a campus like OU, and why a campus like OU is so important, because increasingly, after being a scientist, I started my MD and my PhD in 1980, so I've been at this for 40 years, and getting vaccines from discovery into clinical trials. We're starting to realize we've just done the easy part, because it's all about how you come up with a sustainable business model, or a legal framework, or the social science around vaccines, and the political science. And this is something that's, a place like OU and Norman could really offer, is bringing people together on that front. And this has been one of the big challenges. Now, with coronaviruses, we mutually approached a group at the New York Blood Center a decade ago, because they had an idea behind developing coronavirus vaccines. And more or less, coronavirus vaccines had the same orphan status as vaccines that we were developing for schistosomiasis or Chagas disease. People just didn't care all that much about it, even though we recognized that they're important. So we began developing coronavirus vaccines initially for SARS, if you remember, the severe acute respiratory syndrome that emerged out of southern China in 2003, then Middle Eastern respiratory syndrome in 2012. And we actually found it wasn't that difficult. It was, in some ways, these coronaviruses, even though they were deadly pathogens, were relatively soft targets. In other words, you make an immune response to the spike protein of the virus. And by now, everyone has seen what a cartoon of the coronavirus. It has those spikes emanating all around it. That's what allows it to bind to our host tissues and cause disease. By inducing virus neutralizing antibodies against that spike protein, you can make a vaccine, and with some other components as well. And so we knew this going into January of 2020, and then the Chinese scientists started putting up the genetic code of the SARS-2 coronavirus that causes COVID-19. And this allowed us to kind of hit the ground running in terms of developing coronavirus, a COVID-19 vaccine. So I think, and then I'll turn it over to Mary Elena, but just to say that, there's a lot of this a business of calling it Operation Warp Speed. Everything moves so fast. How can they make a vaccine in a few months? Well, we didn't. It built on a decade of research supported by the NIH and other sources that told us what we had to do in terms of targeting the spike protein, how to make it, what component of the spike protein. So all, people have the impression all this came out of a vacuum, and Moderna and Pfizer came along with some magic technology. It was built on a decade of blood, sweat, and tears by a much greater scientific community.
Thank you. Maria Elena, I wonder if you could build on those remarks and tell us a little about the COVID-19 vaccines that you and Dr. Hotez are currently working on.
Well, first, thank you very much, Dean Roble. It's always a pleasure to see you. Sorry that we cannot actually be with you all there, but we're very excited to have this opportunity. And as Peter mentioned, we're one of the biggest fans of OU. In fact, today we just published a spotlight on some research that one of your faculty has been working on, especially on Chagas disease, Dr. Laura Isobel McCall. So we're very proud that even outside of the COVID-19, we've already had engaged with OU and your faculty in advancing very important research. So to expand a little bit of what Peter said, I think our pillars or philosophy of how we work, knowing that most of the interventions that we need to develop eventually will need to be used by populations all around the world, most of them also in underserved and low middle income countries. Our premise is proven, safe technologies So our distinction maybe between what you hear from other COVID-19s is that we decided to focus on a technology that's already widely used. We in fact created our COVID vaccine leveraging our prior coronavirus knowledge in the backbone of a vaccine that is widely used, which is the hepatitis B vaccine. Hepatitis B is made using a yeast expression system. It's considered a subunit or recombinant protein vaccine technology. In addition to hepatitis B, human papillomavirus, and there's other vaccines that also use the same framework. And I think the reason why we decided to do that and maybe not venture into these novel technologies is because we already knew that if tomorrow we needed to hand over or hand off the recipe, who in the world could already make such a recipe? And hepatitis B is widely made everywhere, right? Asia, Latin America, certainly, low and high middle income countries. We already have an ecosystem, and they don't have to invest into new factories. They don't have to invest into new people. They don't need to learn something new. So in our pillar of production, we decided to make the COVID-19 vaccine with that premise. And in fact, today we can tell you that, it took us 2-3 months to recreate the COVID-19 vaccine. We now have handed it over to a very large vaccine manufacturer in India. It's a company called Biological E, who is one, in fact, of the large multinationals that produce hepatitis B vaccine. And today we know they can make 1.2 billion doses of our vaccine. It took them less than a month or two to see our recipe and being able to reproduce it and scale it. I think that's important, right? Because if we want to make a vaccine for 7 billion people, you need to make sure you can scale it and make it in mass. I think that the other thing that we're very conscious of, as much as we love new technologies, similar to when you buy a new iPhone, today it costs you $500. As more people use it, maybe the cost goes down. And it's the same way with vaccines. Right now, vaccines that use a very platform that everybody already knows how to produce it, the cost of goods are known. We have vaccines that cost less than $3 a dose, which is, in our case, our COVID-19 vaccine, compared to maybe these new technologies that I think they're ranging between $10, $12, $15. And $10 may not sound a lot to us in the US, especially because we have, insurance and third-party payers. But in countries like, Honduras, we can't afford $10 a dose. We have to have vaccines that are pennies on a dose. And so those are the two main reasons why we opted that kind of technology. Plus, what Peter has mentioned, we already knew it worked. It worked for SARS. We knew it worked for MERS. We had a lot of prior evidence. And so now we're really hopeful that this will be the vaccine that will be used in certainly low middle income countries. By the way, Biological E has not only scaled it now, but it has also now started their clinical development plan. They are in a 4 or 5, I believe 5 sites in India, testing what we call phase 1, phase 2 clinical trial to, of course, show safety and efficacy. And then, of course, it's going to be expanded all over the world, hopefully.
Thank you. Thank you. So that takes us to the larger issue of your role and Dr. Hotez's role in adhering to that principle of developing low-cost and affordable vaccines, which can be scaled globally and made accessible to populations in need. Peter, I know that you've received some criticism that you take on directly in the book, Vaccines Did Not Cause Rachel's Autism, some criticism from people on the anti-vaccination movement side of things who say that there's profit to be made in vaccines. And it seems to me very clear that what the two of you are doing is addressing a huge area of need that can be left behind by other pharmaceutical interests. Could you say a little bit more about those global populations with high need and low capacity to afford vaccines that are being produced, or other vaccines that are being produced? What is that sort of gap in the system that has to be filled?
Me or Mary Elena?
I think either and both, yeah.
I'll just say a few words. Yeah, I think this has been, this is one of the reasons why we're always playing catch up whenever we have new pandemics, is because, vaccines are not big financial returns. I mean, some of us have even said that the whole reason that Pfizer and Moderna are in this space right now is, well, one, because of national pride or branding, but also the fact that this is a way for the government to help subsidize advancing their technology, getting the mRNA platform. It's not so much that they're going to make money on COVID-19 vaccines. It's that once that if these can go through regulatory approval, the FDA is essentially providing a glide path. So after the COVID-19 vaccines out, they could flip that around and use it for more lucrative things like cancer vaccines or immune therapies for autism, or even gene delivery technologies. And what's more, it's paid for by the government. So this is like a subsidy. But but it points out the fact that without that, there's no incentive to develop COVID-19 vaccines. So for instance, when you talk to the people at Merck that developed the Ebola vaccine, they did it with some stimulus money from the government as well. But they'll point out, even with that money, they lost money on the project because they had to pull people from money-winning projects to develop that Ebola vaccine, which never had a guaranteed purchase at the end of it. So it goes to show you that we have a broken business model. So again, I get approached by young people all the time telling me they want to go into global health, and they think I'm going to tell them about careers in tropical and infectious diseases. And they're very disappointed when I suggest they get some business training or economics training, because that's where we need the innovation as well in those important areas. So, Mary Elaine and I have been doing this for 20 years. It's all very much seat of the pants in some ways in terms of how you proceed with getting vaccines all the way to licensure and release to the public. And we're learning as we go along. And it is a very fragile global ecosystem, not only because the dollars aren't there, but also we'll talk a little bit later, you have a lot of opposing forces and this very prominent anti-vaccine movement, which, by the way, is very prominent in Oklahoma as well as in Texas, where we are. One of the answers that I've been pushing for is in a previous book, we found that when you look at where a lot of these poverty-related diseases are, we always think about them in the most fragile nation states in places like sub-Saharan Africa, places like Central African Republic or Northern Nigeria or Democratic Republic of Congo. They're certainly there, but on a total numbers basis, they're actually in wealthy countries, the G20 nations, it's the poor living among the wealthy that actually account for most of these illnesses. And COVID-19 is more or less going by the same playbook. It's mainly affecting low-income neighborhoods with essential workers across the world. And it's a concept I call blue marble health, and give it a different name from traditional norms of global health, where we talk about wealthy countries versus poor countries. It says basically overwhelmingly the G20 nations, which account for 86% of the economy, have these poverty-related illnesses, but among people who live in extreme poverty in those nations. And it's a hard concept to get across, but I think it's very important from a policy perspective, because it says that because the G7 countries are getting a bit tapped out, being always asked to provide support for the world, especially the US, UK government and the Gates Foundation. But if we could get better participation in the G20 nations, that might provide a more sustainable financial model. And been trying to get this on the agenda on G20 summits for the last few years. It's still a tough long haul so far.
Yeah. Maria, Elena?
Yes, maybe I can expand a little bit this concept of what Peter is mentioning that requires collaboration, right? I mean, this is the whole premise of working together, and that's why we ourselves are using a model of partnerships, right? You know, create products through partnerships. And I'll give you a perfect example within our region, and I'm going to say the Americas. And even if you look from even the south of the United States all the way down to Central and South America, it's really amazing if you actually look today that there are probably only three relatively prominent vaccine manufacturers in the whole region of Latin America. Brazil, a little bit of Mexico, Cuba, and maybe even Argentina. They only can make vaccines for their own territories. Maybe only Cuba has been shown that is able to even export for the region. So that's not really very good. In fact, you know, the lack of the infrastructure, the capabilities of even coming and being able to solve your own problems, it's concerning. You know, in a pandemic like this, everybody's asking us, who will bring the vaccines to Latin America? And of course, there are these mechanisms through, again, you know, the Global Alliance for Vaccines, CEPI, which is the coalition that is, you know, working to get these funds and these partnerships for epidemic preparedness. But the reality is that everybody's just sitting and waiting for somebody to either come and provide these technologies or these solutions. And it's amazing that with very wealthy countries, and even if you put together the regions, right, you know, right now I'm working very much with trying to, you know, have all the Central American countries, which on aggregate, including the Caribbean, we almost have 90 million people that live in this, you know, region of Central America and the Caribbean, even being considered the 19th economy within the world economy. So it's not little monies that we actually have capacity here, and having zero capability of solving your own production of diagnostics, essential medicines and essential vaccines, it's really disappointing. So moving forward, I think the solution is, again, like Peter said, is as much as we try, is to indeed advocate for, raise the awareness that we need to have self-sustaining, regional sustainable models, especially in this area that, you know, is going to come and solve, you know, pandemic preparedness. And let's not even talk about health systems, right? I mean, we're talking about a collapse in the public health systems, a not having a good primary care of health to be provided to our populations. But I think that's the solution, is through global, local, regional partnership approaches.
Okay, thank you. I do want to make clear to our audience that if you would like to ask questions, you can ask them in the Q&A box, and we would certainly welcome any questions that you have, and I'll convey those to our presenters. I have a couple of questions that sort of are making sense together for me, and I hope they will for you. I'm wondering first about the respective roles of government, private philanthropy, and universities in advancing vaccine research and development, and how those various entities can work most effectively together in the interest of advancing human health. So I know that you know, a number of our audience members are faculty, some graduate students, and they're interested in those partnerships. But I'm also wondering, you know, this is it's a particular moment in time, a moment of change and transition. And as a historian who focuses a lot on the 1930s, I think about the massive changes instituted by FDR and the New Deal administration. And we place a lot of emphasis on the first 100 days. 3 months or so during which the FDR administration made some pretty sweeping changes. I'm wondering about that relationship between government, private philanthropy and universities, but also what could be done in the first 100 days of an administration, a new administration, to really change the game in the arena of vaccine development, distribution, fairness, global equity, etc. It's a big question. I'll throw it out to the two of you.
So Peter, maybe I'll start with the relatively easier answer, which is part A of, why certainly the academic research and development is the pillar, is actually the genesis of why we do have some very important innovations and novel technologies, especially global health technologies. And the reality is that we academics are the ones who come up with like the light bulbs that light up, right? We're the ones who come up with the creative ideas, with the new innovations. Now, I think, in the maybe last couple of decades, organizations, as us, academics that are also quite becoming a surrogate of biotechnology, and maybe even surrogate of pharma, right? Where they look to us now to not only provide the invention, and somebody else will take it on and advance it in some black box that we never know what's happening within the pharma sphere. Now more and more we're replacing some of those biopharma roles, like indeed bringing our own discoveries to translating it into an actual product. More and more our institutions are developing, like Peter was saying, the business models, the economics, the legal frameworks, the ethical frameworks. More and more we're like mini biotechnology companies, right? And so we're actually seeing that replacement. And in fact, where do we get the funding, right? And I have to tell you very graciously, $12 billion were invested in this whole Operation Warp Speed. I think on aggregate, certainly we personally did not receive a penny from that framework, but where do we get our bread and butter is certainly our traditional, NIH, applying for grants and any other grants. But who came to save the day for us have been philanthropic foundations. I mean, we certainly don't have the billions of dollars. We, albeit, don't even reach the millions, maybe a few millions, but who have come and supported us is a whole ecosystem of foundations, whether they're private, family, even high net worth individuals, or even the common people. $10 at a time, we created a fund that allowed us to bring our COVID-19 vaccine to being able to transition it to already being a product. So that is why I think the cultivation within our institutions, with our own, local, certainly regional, state, philanthropic organizations, they have been stepping up. I mean, we have examples, even, for example, locally, we have Tito's Vodka. Who would know, right? An organization such as Tito's Vodka in investing in research. Foundations like the Kleberg Foundation, who the family owns the big ranches, the big cattle ranches in Texas, right? Because they are really looking for supporting our own communities. So maybe now I pass it on to Peter to speak a little bit more how that also helps build this, what should be the 100 days of the new administration, how should it look like? Because I think it's also quite interesting to hear.
Yeah, I mean, I agree with Mary Elaine. I mean, one of the problems that we have is the traditional model that goes something like as follows. Let's say you're a professor of chemistry at OU and you make a discovery. What you then do is have your university license office try to shop it around and see if they can find a company that will want to adopt a license from University of Oklahoma and then pursue it. But, for something like vaccines, that system often breaks down. Sometimes it works, but more often than not, it doesn't, because there's still a need to have funds to get you through those early stages of product development within the university. And this is One of the things that we've tried to do at Texas Children's Hospital, try to do the early stage fermentation product development on campus to shepherd it along at a certain level. Then it makes it more attractive to a place like BioE in India, which now can scale it up to 1 billion. In other words, there's there's a gap, what we sometimes call the valley of death, between basic research and then scale up production. And there's that intermediate step. And the way the US government usually handles it are through small businesses, small business innovation research grants. It still doesn't work for things like us because there's just no profit incentive. So we've adopted this model to do some of the early stage development on campus. I think OU has that capacity. They've done it a little bit. University of Nebraska, Lincoln now has had some capacity for that, I think through their Department of Chemical Engineering, but it's pretty uncommon. In terms of the first 100 days of the Biden administration, I have a paper that's up in, so only 6 people would read it. I put it up in Microbes and Infection. But I'm joking. It'll be out. It's out there on social media. But it basically says the following. Look, we're going to go through a very dark period over the next few months, and I think Oklahoma is going to get hit pretty hard with COVID-19. Hopefully not as bad as North Dakota, South Dakota, but I think that's a real possibility. And the reason is we're just starting to see these surges on intensive care units because we're not social distancing, we're not wearing masks. It's a particular problem in the middle part of the country, in the heartland, and in Texas and Oklahoma. And we could talk about why. And so we are going to be surging to 2,000 deaths per day, then 3,000 deaths per day. Some say 4,000 deaths per day. And when you look at those kinds of numbers, by the time a week or so after the inauguration rolls around, we could be looking at 500,000 Americans who lose their lives from COVID-19. So it's going to be a very bleak type of situation the Biden administration inherits. This lame duck session has turned out to be one of the deadliest in American history. And I think maybe we have to revisit the whole concept of lame duck and what that means. And I think when you get that level of people losing their lives or being hospitalized, what it means practically speaking is every single person in the country will know someone who's been seriously ill from COVID-19. And I think that will have a pretty chilling effect on a number of levels in terms of people feeling secure. So I think it's going to affect Homeland Security. I think we'll see levels of food insecurity. Certainly the economy will suffer because of that. So it's a long way of saying I think we're going to be in a very pretty dire situation when January rolls around. The good news is vaccines are coming and we'll start vaccinating the population. So the key now is making certain we can get everybody through to the other side. The thing that I'm worried about is people are unnecessarily going to be taking risks, either defiant of wearing masks or social distancing, and lose their lives. And the point is, all we need to do is hang on a couple of more months, get everybody to the other side and get them vaccinated, and they can live their normal lifespan. And that seems, for me, that's been a big priority. And I'm not really seeing that happen. We're not really getting the leadership out of the White House that we need to make that happen. Some of the governors are getting it. Some of the governors are not getting it. If you look at the 12 states right now that are most affected in the country, 10 of them are red states. So only 2 of the 12 are blue states. That's Minnesota and New Mexico, but otherwise they're red states. And, I don't know how much the Biden administration is really going to reach across the aisle. We're going to need Republican champions to help us through that. When you look at the coronavirus task force that he's selected, all 13 members are from blue states. In fact, they're all, except for 2, they're all flyover nation. It's all Acela corridor, New York, Philadelphia, Washington, Boston, or San Francisco. And I think we've just got to fix that. We really need to be able to start bridging these gaps. It's going to be critically important. So that's one of the things the paper says. The other is that this concept of the White House Coronavirus Task Force, it sounded good in principle. I think it was poorly executed in the Trump administration. We never really got the level of communication. We never really got a national program together. It was always let the states be out in the lead, and then the U.S. government would provide the backup support in terms of production capability, manufacturing, ventilators and masks, and supply chain management, FEMA support. And that was useful, but it wasn't the same as having the federal government out in front in the lead. And the problem was, by leaving it to the states, I think a lot of the states did not have the intellectual horsepower to know how to do this. They didn't have the epidemiologic models. They didn't know how to actually contain something as complicated as COVID-19, because it has a unique complexity, and that is it's got what I call a Janus face to it. You, on the one hand, you have people getting very sick and going to intensive care, and the other hand, you have people who are asymptomatic and are just shedding virus. And that simple reality has created all the complexities that we have today. Lots of people with shedding virus in their mouth and upper airway, and as they're speaking, and then others really getting sick. And that required an unprecedented level of coordination to contain. And without having the federal government in the lead, leaving it to the states, I think it was catastrophic. And that's why we'll have so many American lives lost. So bringing that back and have a federally led program is going to be important. I think to depoliticize it, I've recommended taking it out of Washington, D.C. The task force, the concept of the task force has lost credibility with the American people. Bring it to the Centers for Disease Control, run it out of Atlanta, even knowing that the CDC made some big mistakes this past year. They missed the entry of the virus from Europe into New York. They messed up the testing in the beginning. Even with that, I think I don't see another way around it, but other than have a federally led response coming out of Atlanta and led by the CDC. And I think that could work, particularly now that we have vaccines and other biologics. I think that's going to make it a lot easier.
Peter, that's a sobering set of reflections and predictions, and it's prompted a number of questions from our audience. And I'd like to turn to some of those questions, and I'll put two or three together here. One question concerns the number of deaths a day in nationally and in Oklahoma. And I think when you were talking about 2,000 going up to 3,000 and perhaps 4,000 deaths a day, that's a national.
That's national, correct? Yeah.
But
remember what that number means.
Right.
That means on a daily basis, COVID-19 will be the single leading cause of death in the United States. Just by going over 2,500 to 3,000, that COVID-19 becomes the single leading cause of death in the country.
Okay. So one of our questions is, can you address the risks posed to vaccinated individuals? So the risks posed to vaccinated individuals, so we're speaking a few months out now, from those who refuse to take the vaccine and from those who currently do not have access to the vaccine, but will receive it at some point in the future. So I guess when we talk about the first vaccinated individuals, I'm presuming they would be essential workers, healthcare workers, and other essential services. So are they at risk from those who refuse to take the vaccine or from the larger unvaccinated population?
Well, I'll say something, and then maybe Mary Elena. There's two things you want a vaccine to do. One, if you get vaccinated, you want to know you're not going into the hospital or the intensive care unit. And now, again, all of the information we have on the efficacy of these vaccines is coming from company press releases, which has been a big problem of not having a communication strategy out of Operation Warp Speed. When a company sends out a press release, they're not writing it for you, David, or for me or Mary Elena. They're writing it for their shareholders. So let's hope what actually is in those press releases is accurate. But assuming it is, then it looks like these vaccines are functioning at a pretty high level of efficacy. And it means that if you get vaccinated, you will be likely not going into the intensive care unit or the hospital, which itself would be game changing. We don't know anything about the durability of protection because these are new technologies. I mean, Mary Lane and I are using a traditional technology that we're scaling up in India that's been around for 35, 40 years, used to make the recombinant hepatitis B vaccine. But this is a brand new technology. And we don't know, is it going to last 3 months, 3 years, 30 years? And that's, again, why we're going to have a lot of communication and situational awareness. Then the other problem is we don't know the full performance of these vaccines. Is it going, let's say you get vaccinated and it prevents you from getting sick enough to go to the ICU or hospital or be hospitalized. That's extremely important. But might you still have the infection? Might you still be shedding, become like an asymptomatic shedder and still be shedding virus? Because if that's the case, it means we're still going to need masks and social distancing. And again, none of that is being messaged, right? It's people are surprised often to hear that. And now Larry Corey, who's running the clinical trials, sort of the mastermind of the clinical trials coming out of the University of Washington, Seattle, has indicated they're going to look at doing exactly that trial to show that it interrupt transmission. Because if it does, and if it does stop virus shedding, then if we can convince enough people to get vaccinated, and Mary Lane and I did a study with a group at City University of New York to show that it requires 70% of the population to be vaccinated if it has those performance characteristics. So that's a pretty high bar. You need a high performing vaccine and a very high percentage. So I think the virus is going to be around for a while. Even after people are vaccinated and not going into the ICU, we're going to need an interim strategy for dealing with all this. Moncef Slaoui, who's the head of the Operation Warp Speed program, said on one of the weekend talk shows that he thinks we'll have herd immunity by the spring and stopping transmission. And to me, that's an aspirational goal at best. I don't quite, maybe he has access to data that we don't, but I don't see that happening. Having said that, we're going to be in a much better position by this time next year. We're going to be in a much better position in the summer, maybe late in the spring. So life is going to get much better, but it's going to be a slowly evolving improvement. Starting when vaccines get released by the end of December, every subsequent month, things are going to get a little bit better, a little bit better, a little bit better. We'll feel more comfortable. We'll know we're not going to the ICU or hospital as we get vaccinated. We may start seeing declines in transmission, but it's not going to be this toggle switch. It's not going to be a light switch going on and off. It's going to take time to evolve.
Maybe I can add a little bit on that note that, as you know, yes, these information that we only see in press releases are submitted to the US FDA. And now we know, or at least for 2, Moderna and Pfizer, that the Advisory Committee on Immunization Practices is going to be meeting and reviewing all this. But also we have to be very cautious, because the way that they're going to be distributing, if indeed it receives emergency authorization approval, is through these phased approaches, right? The phase 1A, phase 1B, phase 1C, and then phase 2. And right now the urgency is that this phase 1A, which will probably occur in the next, between December 10 and December 30, is really the high, our primary, our healthcare workers, those who are being exposed in these hospital settings that Peter is mentioning, right? Direct patient care. And we probably are going to start seeing all the other populations, in 10 to 15 weeks afterwards. Now, the other thing that we need to remember is not only that these trials were designed, like Peter said, to see if these vaccines can reduce the severity of the disease, but also we have to be conscious that not all the populations have been evaluated either, right? So we know, for example, Pfizer is from 12 years of age above, but we also have all the population 12 years of age below. So there are clearly no studies yet on pediatrics. So those might be other studies that we need to continue following up. There are no studies in pregnant women. There are, of course, some extension of the age range, maybe in above 65 years of age. But, like in my family, for example, my father is almost 90, and I don't think there are any vaccines right now that are being evaluated above the age of 90, right? Or how many were included in those studies above that, real elderly ages. So there's still a lot of things that we need to know. So likelihood, is that Peter said, it will require a little bit more time before you and I most likely are going to be able to even access or being part of these groups that can receive the vaccines.
Thank you. We've got some really wonderful questions in the chat, and well, in the Q&A section. It's not in the chat, and I'd like to try and pull some of those together. First, one dealing with health disparities for Hispanic and other minority populations in the US regarding COVID-19. And the question is, what can we do as a society to prevent these health inequities from being accepted as just the sort of, the cost of the pandemic in the United States? How can we direct attention to those health disparity needs of at-risk populations?
I'll let Mary Elena. Hey, Mary Elena, go first. You.
Well, sure. I mean, first of all, I think even going back to what Peter had mentioned, it's all in how you engage and how you communicate with those populations, and if you even scout, how the information is being provided, it's very lacking. So there was a moment even that, if you look at the design of these clinical trials, there were a huge concern that most of the even participants were not reflective of some of the populations in our communities. And I think, again, it's the lack of the ability of really framing the information in a way that it is also accessible in different languages, and in certainly, of course, different regions. And the way that you speak to different cultures is probably very different, right? Depending on, of course, their historical, even just understanding of, vaccines, or even the access to healthcare. So I think communications is a key. I think second is that we do know that within our cities, there's always the tendency that, the regions where the underserved populations are the ones who also have the lower access to just, primary care, or even access to nutritious foods. Working with, for example, even our supermarkets, the fact that, for you to go to a supermarket or to even purchase healthy foods, you have to have a social economic status. If not, you end up, buying a lot of soda and buying a lot of probably, chips, because you can't afford, fresh fruits. So I think that it's really changing the way that we also, as communicators, present the information to be more inclusive, and invite them, to have a seat at the table, right? I think that that's the other distinction, that we don't still see a lot of those who are in leadership positions representing, such communities. So I think it's inviting them too.
Thank you.
Yeah, and I would say, we've really seen the Hispanic community and the African American communities decimated, and Native American communities decimated by this epidemic. And, while the narrative out there, it's mostly people over the age of 65, we're seeing 30 to 35% of the deaths in those groups are under the age of 65. So what you're seeing are a lot of, and if you look at the Hispanic, Native American, African American communities, they combine about a third of the population of the U.S., and a third of those deaths are under the age of 65. So it's robbing, homes and families of mothers and fathers and brothers or sisters, and that's a tragedy that's not really being emphasized. When we get every day in the Houston Health Department the list of people who've died the day before from COVID-19. It doesn't provide the names, but it provides sex, age, and race or ethnicity. every day it's the same thing: Hispanic, 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 Black, Black, Hispanic, Hispanic. So this is just decimating, especially low-income neighborhoods where you have essential workers that are working on construction sites or on family-owned businesses, and they're often multi-generational homes. So they're going home to their parents. If it's a 20-year-old on a construction site, he or she's going home to their mother and father or their grandmother and grandfather, and that's where the devastation is really occurring. And we haven't addressed it. And I testified on this to the Congressional Hispanic Caucus, and it was the first time people had even really heard about it. So we've got to do a better job, and especially when it comes to vaccinating, because one of the things the anti-vaccines groups have been doing is they've been targeting minority communities with misinformation or disinformation. So they've been, one of the lead anti-vaccine organizations called Children's Health Defense, which is run by Robert F. Kennedy Jr., has been staging rallies in Harlem, calling vaccines the next Tuskegee experiment and all this kind of stuff, very inflammatory language. And we have to kind of figure out a way to get our arms around this and launch a counteroffensive. And so far, there's not been a lot of appetite for doing that.
Thank you. In the interest of time, I'm going to take a series of questions that are all related to anti-vaccination sentiments and efforts. And I'm just going to recount the questions for you and then ask you both to address the issue of anti-vaccination thinking. So one question is, where does the science come from that questions the safety of vaccines? And the question asker goes on to say, Rotary International has been trying to eradicate polio globally, and some field personnel administering vaccines have been murdered. Another audience member says, should we make stimulus payments contingent on getting a COVID-19 vaccination if it's available? You want your stimulus payment, make sure you get the vaccination. How should the medical community and government deal with the many people who will refuse to take the COVID-19 vaccine? What will those refusals do in terms of the larger community's safety? Let me just get a couple more of these similar kinds of questions related to the anti-vaccination sentiment and movement on the table. What are your thoughts about the anti-mask movement? Is it too late to decrease this sentiment, especially in rural and red areas? Another question is, what are the key drivers or incentives in the anti-vaccination movement? What are the goals of these groups? Do they really believe vaccines are not safe? Are they gaining financially? Do anti-vax attitudes align with other ideological positions? And then the last one in this category, I have a friend who's deeply suspicious of government efforts to vaccinate citizens. He's a staunch individualist, doesn't respond well when people tell him what he needs to do. What would you tell him? So a whole series of questions there related to anti-vaccination sentiments.
I can give a brief narrative, and I get involved in this because, of course, I have a daughter with autism, and I'm targeted a lot by the anti-vaccine groups, especially here in Texas. So, this modern day idea that vaccines are bad, it's not the first time in American history we've had this. It's gone even as far back as colonial times, when people wanted to vaccinate. Cotton Mather wanted to variolate the colonies. That there were efforts to stop that, but the modern framework really began in the early 2000s with these fake claims that vaccines cause autism, and it came out of a fraudulent paper that was published in The Lancet in 1998, claiming that the measles, mumps, rubella vaccine causes autism, and that got refuted by the scientific community. It showed that kids who got the MMR vaccine, the measles, mumps, rubella vaccine, were no more likely to get autism than kids who didn't. And conversely, kids who were on the autism spectrum were no more likely to have gotten MMR than not. And so that was pretty clear. But then the anti-vaccine groups started moving the goalposts. They said, okay, we didn't mean the MMR vaccine. We meant the thimerosal preservative that used to be in vaccine. Then it morphed again to spacing vaccines close together, and then morphed again to aluminum in vaccines. And it was all fake. But what happened was in 2015, it took a political turn. And under this banner that's called health freedom or medical freedom, it started getting funding from political extremist groups on the far right, and a lot of it from the Tea Party. And it was really prominent in this part of the country. This is when you had Texans for Vaccine Choice starting, Oklahomans for Vaccine Choice. They become 501c4 organizations, PACs, that would lobby the state legislature under this fake banner of health freedom or medical freedom. They were very powerful and very persuasive, and they had a lot of bandwidth on the internet, on social media platforms. I mean, e-commerce platforms. If you go to the Amazon.com site and put in books and then go to health, fitness, and dieting, and then all vaccinations, they're all fake anti-vaccine books, and a lot of them are coming out of Texas and Oklahoma. And then in 2020, under that same banner of health freedom, those same anti-vaccine groups just glommed on protests against masks and contact tracing and social distancing, all under this banner of health freedom and medical freedom. But it really revved up around about 5 years ago, and with this link to the far political right. And it's been very damaging, and it's really taken off in the middle part of the country. And then you started having national groups form, like Robert F. Kennedy Jr.'s Children's Health Defense, and they dominate the internet. By some accounts, there's more than 500 fake anti-vaccine websites, all revved up on the e-commerce sites like Amazon and Facebook and social media, so that if you're a parent or if anyone trying to download information about whether it's COVID vaccines or childhood vaccines, you're going to get garbage. You're going to get mostly, it's hard to find real information. And now it's even expanded into Western Europe using the same language that's coming out of Oklahoma and Texas. So there were rallies over this past year and still ongoing. There was one this past weekend in London against masks and social distancing, and also anti-vaccine. And in the case of the rallies in Berlin, CBS News and others have reported there was an attempt to storm the Reichstag, the German parliament, and it was linked to QAnon and even neo-Nazi groups. So it's taken this very dark turn. So, how you bring it all back is going to be really tough. There's a lot of effort now to try to fine tune the message, shape the message to get people to take the vaccine. But I contend all this message shaping and tuning and expansion will get us less than halfway there until we take down the anti-vaccine confederacy or empire, and because it's just so pervasive and it's taken all these odd turns. Then you got the Russians now filling our internet with anti-vaccine, anti-COVID-19 prevention measures. And there's even a new term that's been coined by social scientists called weaponized health communication. This is what the Putin government is doing through Russia today, what they call RT. But how you explain that to rational audiences is tough. I mean, just listen. As I hear myself speak, right? You start talking about Nazis and QAnon and the Russians, and you start sounding like somebody who's pretty unhinged, who throws things at the TV at night. And so we've got to figure out a way to make this more intelligible and to document it better. But it's clear we are in a whole new time of anti-science, and it's very aggressive, targeting scientists, and it's got money, it's got power, and we're going to have to figure out a way how we begin dismantling it.
Thanks, Peter. I mean, I would say that as a reader of your work, the passages towards the end of your book, Vaccines Did Not Cause Rachel's Autism, I found profoundly moving, where you're trying to explain that, look, I have an autistic daughter. This is why you need to be absolutely assured that vaccines are not the cause of Rachel's autism. And you provide it as clearly as I can recall vaccine science being presented by anybody. It's done with great clarity and effectiveness.
Yeah. I mean, part of the problem, is this, getting into this space and taking it on, because as scientists, especially at a publicly funded university, and here at Baylor College of Medicine, because we get public funds as well. The message is, don't go into politics when your public remarks, just stick to the science, stick to the science. And the problem is this: we didn't do this. It's this whole anti-science movement has been linked to political extremism, and it's very hard to disentangle it. And it's hard to go up against anti-science groups without getting your hands dirty talking about politics. And state universities don't like it because it puts you in that very awkward position. Fortunately, my boss has been pretty good about it, but it's tough, especially for a professor at OU wants to take this on. It means going into dark areas and going into messy areas that are often not looked upon favorably by us, David, as deans. I'm a dean
Right.
now too, and I've gone over to the dark side too, right? I'm a dean, so I'm part of the problem, right? So, but how you manage that is very challenging.
Well, I'd like to close with take us back to the science, and a final question from our audience that deals directly with the science. So how does the cost of manufacturing a traditional protein-based vaccine compare to that of the newer nucleic acid-based vaccines? I wonder if we could, we'll close with a science question.
Well, maybe I can just, a couple of comments, and I think, putting together all that we have been saying, and maybe the anxiety of, are we really going to be able to come back to the science? One of our colleagues reminded us, how did we manage in the United States to agree that we should not be smoking in public, that we therefore, are able to really allow for public health decisions that are driven for the benefit of the public or the public good. And I think that's going to be maybe using some of those certainly, stories that we've seen that has not been easy, but we can probably accomplish them. We know that with everything, again, the science has told us that we need to invest in it, and we need to certainly advance it and look for innovations. But sometimes for a problem of this magnitude, we may not necessarily have to reinvent something that we already probably had almost ready. And I think maybe one of the mistakes was to bank too much into this concept that we required speed. But at the end of the day, when you maybe had a very good speed in producing the RNA as a piece of molecule, but when you started looking at packaging it, delivering it, the cold chain requirements, the fact that there is not a lot of people who can make it at large scales, and that the costs are going to be high, by that time we finally found ourselves that we caught up, and that we probably now, maybe just with a couple of months, are going to be able to use even the traditional technologies. And we should have probably focused on that, from early on, rather than, relegating them to, oh, we really need something a little bit more sophisticated and that gives us some speed. So, but we have a lot of hope. There's going to be a lot of vaccines coming out, and I think now we just need to keep the science, front and center, so that we can make the best decisions.
So warp speed as a concept may have warped our sense of the value of the science that had already been done.
Correct.
Peter, closing thoughts?
Yeah, I would say that also. I think the other, as I say, the spike protein of the coronavirus is a relatively soft target. Or Carl Zimmer, the science writer, calls the COVID-19 virus clumsy prey, meaning you get a lot of antibodies to the spike protein, you'll get a successful vaccine. And I think there's going to be multiple ones. The challenge is going to be moving forward. We may not be so lucky the next pathogen around. I mean, we were able to move pretty quickly on COVID-19. And people think it's some miracle of science, and it is in a sense, but it was also, we got a bit lucky in the way that it's relatively straightforward to target. But we're still scratching our heads about malaria vaccines and TB vaccines and HIV/AIDS vaccines, and it still requires decades of R&D investment. So keeping all that going, I think, is going to be really important, because the next pathogen that comes around may not be so straightforward.
Thank you. I'd like to thank you both, Maria, Elena, and Peter, for spending this time with us and for enlightening us on one of the most pressing issues of our day. Thank you both for the work that you're doing, and thanks to our audience for joining us today.
Thank you.
Stay safe, everybody.
Thank you, and thanks to OU for all the great work you're doing.
Thank you.
Thank you very much.
All right, take care, everybody. Thanks again, Peter. Thanks, Maria, Elena.
Thank you. It was great. I loved it.
Okay.
Bye-bye.
Bye-bye.